evidence-based medicine on which the treatment is based is gradually evolving. So be aware of that. So I would request our moderator, Dr. Debashish Datta, to take us forward. Thank you very much.
Thank you very much, Kaushik, and welcome to all the participants. As Kaushik mentioned, this is a discussion on COVID. I think the plan is we will cover as much as possible over the next hour or so. You have sent me already about 20 questions. We'll definitely try to cover those also. And keep sending the questions in your chat box if you have any during the discussion. Now, before starting, let me introduce the galaxy of our panelists today, who are all very experienced and well-known. We have got two panelists from UK. I would request when I mention their name to raise their hands so the participants can recognize them. The participants from UK are Dr. Soumitra Bokshi and Dr. Jayanta Mukherjee. They're both COVID warriors. They have actually seen what's happened in UK. They have worked from the front line, and you will get a wonderful overview from them regarding this. From India, we have got Kaushik Pandit, who's just spoken to you. He's a senior diabetologist. We have got Dr. Pallab Chatterjee, who is a very senior pediatrician. And we have our old Dr. Chinmoy Maiti. Now, Chinmoy is again working from the front line here. He is working tirelessly now, and I'm very grateful to him that he has come to the seminar today. We will also hopefully get Dr. Sumit Sengupta, who is actually at a meeting with the West Bengal government thing, but he will join later. I am Debashish Datta. I am a gastroenterologist, but I'm in the privileged position today to ask questions, so I don't have to answer anything. So may I start with Dr. Soumitra Bokshi? I think we'll start with the simple things. Soumitra, can you please tell us something about the virology of this virus? What type of virus? Please tell us, please enlighten us. You can share the screen.
Okay, thanks, Didi. I will don't make it too complex. So this, what is the COVID virus is, the reason it's called coronavirus is because of these yellow things, which are the spike protein, looks like a crown. So you've actually got 4 proteins in there. The M protein, which is a membrane protein, the N is the nucleoside, but the S protein, which is the spike protein, is the most important thing, and against which the vaccines are being produced. So this is the brief structure of the RNA virus. It's an RNA virus, as you all know. Now, this is how it affects the cell. So you get the ACE2 receptor, which is the receptor through which it blocks. Then you get this transmembrane serine protein serinase 2, which then activates, gets the virus in, you get the RNA, and then it replicates, and then the cell dies, and other viruses are coming out. So I'll come to the mutation in a later stage. This is the important thing you need to know, that people get confused about RT-PCR, etc. So during the first few days of the illness, you get the viral response, when you tend to usually get the upper respiratory symptoms like loss of smell, a bit of cough and nasal symptoms. But then when your lung problem starts, which is usually down around the 7th to 10th day, it's actually the inflammatory response that drives it. So then the patient tends to get unwell. And this is the reason will come later that the steroids tend to work in this situation. Steroids don't work very well in the early part because it's the immune response that's going to suppress. Okay, the way it works, you get your ACE2 receptor, and this is the type 2 alveolar pneumocytes. The cell comes in, as I said previously, there's an apoptotic cell, the viruses come out, and what happens then, the macrophages take up these viruses. As they take up these viruses, you start getting IL-6, IL-1, all these mediators coming in. At the same time, activating the T lymphocytes, the B lymphocytes, and then further activation of the cascade, and you get the cytokine storm, and all this leading to necrosis of cells, further efflux of leukocytes, free radical damage, dilatation of the blood vessel. So this is one pathway. The second thing that happens, this is very peculiar to the SARS-CoV-2 virus, it directly affects the endothelial cells. And as you know, vascular problem is a huge problem in COVID, and directly activating the endothelial cells leading to vascular thrombosis, and you get vasoplagia and all that in the lung. The third mechanism is as it affects the ACE2 receptor, you then get uninhibited action of angiotensin 2. And from your physiology days, you will know that angiotensin 2 leads to further inflammation, which we tend to see in people with hypertension. So that's the brief mechanism of action. And this is briefly what ACE2 receptor does. So normally the ACE inhibitor drugs block your angiotensin to angiotensin 2. But then your ACE2 receptor actually is important in breaking down this angiotensin 2. Now, as you block your ACE2 receptor with the virus, this angiotensin 2 now goes unchecked, leading to further inflammation. I think that's the very brief sort of pathophysiology of the virus.
Thank you, Soumitra.
Okay, I'll stop sharing.
Thank you, Soumitra. I think that pathogenesis is always important. So I think that's a good start. But there are many questions, so I will move swiftly forward. Can I ask Paulo? There has been a lot of debate about transmission of this virus. Can you just update us how the virus gets transmitted?
Look here, what happened initially was we, as Soumitra just now said, that whatever happens, the entry of the virus is through the respiratory system. So that is the pathway of the entry of the virus, and that is how it gets transmitted. Now, initially, all this problem started and all the controversy started because WHO categorically said that it does not transmit by aerosol. They even tweeted, and that tweet is still there, that it is only droplets and not aerosol. Now, there's a very small difference between droplets and aerosol. Basically, if it's more than 5 microns, then the particles tend to fall closer. And so if you're not very close to the person, if it doesn't sneeze or cough on you, then it's very difficult to get the virus. On the other hand, if it's an aerosol, if it's a very small particle, and that particle tends to stay in the room. So supposing you were a person who's a COVID-19 infected person was in the room, he's walked out of the room, and you get into the room, the aerosol is there in the room. So you can inhale that aerosol and you can get the infection. So the aerosol method of transmission is pretty serious. And now it has been proven beyond doubt that this virus transmits by aerosol also. So basically respiratory transmission. And it's been found also certain variants can stay in the aerosol form for around 2 to 4 hours. The other forms of transmission that we are worried about is the fomites. Somebody coughs or sneezes, or a person touches, and then you touch that and you get the infection. That is not that important. But yes, if it's a very seriously infected, contaminated object, and you touch that, and then you touch one of your mucous membranes, then you can get it. So theoretically, yes, possible. But the amount of virus that has to be there on the fomite to get into your system is a lot. So fomites are not that important. The last part that we are worried about is the pregnant mothers, whether it's transmitted vertically, whether it's transmitted.
We'll come to that, Pallav. Sorry to interrupt.
Okay, yeah.
We'll come to that in a minute. I think so. You're talking about there is chance of airborne transmission.
Yes.
So small droplets and large droplets, and it stays in the air. And I think this is a new theory coming up. There has been a question: can it spread? Can it be spread by breathing only? So someone get, if someone is an infected person is breathing, will it come out?
Yes, it's not breathing only, but rather it's talking. So if somebody is talking loudly, then yes, he can produce aerosols. Yes. And again, how close you are to that person, how long you are with that person. So staying for more than 15 minutes with that person in the same room, there's a high chance.
So going from there, Joyanto, if I may ask you, what are the risk factors which makes people prone to get this infection? John.
Thank you, Debashish. So when I'm assessing a patient with COVID, be it as an outpatient scenario or inpatient, we bear in mind that there are about 80% of such patients on an average will have a milder outcome, and probably most of them can be managed at home. However, there is this 20% who may need hospital admission, and the 5% with severe illness may need critical care help, some of them. So the challenge is finding out which group they are initially and also later on, because we know a patient from milder group can move on to severe group. So when we are assessing, the important things to take into mind is the factors that the patient brings, most important being age. So for example, somebody who is over 80 has unfortunately got a more than 20 times the chance of death as opposed to somebody who is just over 50. So that's the, on that length, the other important factors are chronic lung disease, being a respiratory physician, but not every lung disease is equally important. Asthma, for example, may not be necessarily very important if it is well controlled, but severe lung disease are important. People on steroid therapy are important. People with cancer are important. So when we are assessing them, we would assess their breathlessness, whether they are very severely dyspneic or not, whether they are very severely hypoxic or not. These are the clinical assessments that we will carry out. And then in terms of investigations, I don't think they are at the baseline, we do a lot of them, but certainly if they have got a very high inflammatory markers or a very low lymphocyte count.
We'll come to that. I think we'll come to the laboratory markers, but what you are saying is that the risk factors which will make them prone. I've just added Dr. Taposh Bandhavada to the panelist list. He's from USA, so he's very senior consultant, so he will also give his views from the USA, I hope, Taposh. Now, moving on from the risk factors and the prevention, Kaushik, if I may go back to you, from there, what is the prevention? How can a normal person stop the infection? Do not talk about the vaccines because we'll do it at the end, but apart from the vaccine, what are the preventive measures one can take? Please unmute yourself, Kaushik.
I'm sorry. This has been said time and again that it is very important that it is the distance that really matters. So that's why everybody is saying in simple terms also, do gaz ki duri. And that's how you probably, I mean, dispel this aerosols to reach you. Other than that, of course, the masks are really very efficacious. They have been proved beyond doubt. And in situations of excessive chances of infection, you can use double masking also. That actually the chances of infection goes down significantly low. As Pallav has already said, that chances by fomite are much less. Of course, we will be do better if we can use some other agents like something like sanitizing agent, we can decrease the chances, but predominantly it is the mask that actually helps in preventing the infection.
And if I may add, Kaushik, wearing the mask properly, not putting the mask under their chin or under their nose. So I think for all the participants in the job, I think you must emphasize to the people you meet to wear the mask properly. I think that's what we see is a great concern to, I think, all of us. Pallav.
Just a small point I wanted to make is we have to do SMS. SMS means sanitization, mask, and social distancing. That is all.
That's a good way to say this. So, Soumitra, I would like to come to you about the new variants. As I think it has been proposed, all this new problem which we are facing, the second peak or the third peak, there's a huge problem with the variants. So if you can tell us briefly what are the variants which we are encountering, and if you may say why does the variance happen?
Okay. So what exactly is a variant? It's basically, we think it's not going to happen. Now, coronavirus has already got about 400,000 mutations. Now, most of these mutations don't sort of mean anything. So mutation is basically a change in the sequence of the proteins, and mostly what we're interested in is the spike protein. Now, variant is where these genomes that vary in sequence. Now, to make things very simpler, why do we call it a strain is a variant now that has got, which is a different phenotype, particularly if it becomes more virulent. Now, the first variant that we started was this is called the B117, that was the UK, was in the Kent. Now, when this COVID thing started, this was the predominant variant that was found in Punjab. That's how it started. However, the new variant that has been found, this forgive me for not putting the dot, is B.1.617, that came out as the predominant variant in Maharashtra. So this basically has got two mutations at the position 452 and 484. Now, actually, if you look at it, this first mutation was identified in a virus in California, and the second was in South Africa. But all these were individual mutations. What India has done is combined the two. So there is the variant. Now, what has also now been recognized, there are two more variants come out. It's actually, I read it this morning, that it is now, this variant is called B.1.617.1. There is B.617.2 and B.617.3. So we don't know a lot about them yet because there's a sort of research going on, and there's a big project in UK actually looking at this Indian variant. So far, it has not been proven that this variant is more virulent than the other viruses. However, they are much more transmissible, so far we know. That is because their affinity to the ACE receptors more, that's why probably they're much more easily transmissible.
I think that's what we are experiencing here also, Soumitra.
Yes.
I just wanted to ask you briefly, sorry to interrupt, just wanted to ask you, how does the variance happen? How can we stop it from happening? Is there any way, is there any precaution we can take?
The most important precaution is to, as Pallav and Kaushik has said about transmission. So you reduce the transmission. This is the natural process of the virus. The only thing we can do is to reduce the transmission. That's all we can do. It is the natural process of the virus. So they will keep mutating. They will just keep mutating.
Okay.
And the other thing with the vaccine is, so far we know that the vaccine still works. We do not know that it doesn't work. So people need vaccination, they should still have it, not thinking, oh, this thing doesn't work against the Indian variant. So far it's not been proven. So my request is, if somebody is offered vaccination.
I think that's we must talk about the vaccination. Now, I think one thing we haven't mentioned in the prevention, anyone can answer this one, is contact tracing and how long someone should quarantine. Pallav, you're going to say something?
No, I just wanted to say that after that two mutations, we have now a 3 mutant variant, which is very prevalent in West Bengal now. And that is the B.1.618. So that is the one that is now prevalent in West Bengal. So that is the 3 mutations.
Anyone want to talk about contact tracing? I think to prevent further infection, I think it's very important that we do mention test and treat, and sort of get the patient to quarantine so that there is less transmission. Now, I think we have discussed this. Let's move on to the presentation. So Chinmay, if I may bring you in, a patient is at home. What are the symptoms they will experience when they will suspect that they have COVID infection? Chinmay.
Hello.
We can hear you.
Good evening, everyone. Yeah, I think a nice discussion going on. I think as I think Jayanto probably mentioned partly. So most of the infections, COVID infections, are asymptomatic or mild infection. Okay, so about overall 50% is asymptomatic. About 30 to 35%.
Chinmay, we'll come to that. The specific question I had is, when do you people suspect that they have COVID infection? What are the symptoms someone will get at home? What are we talking about symptom-wise?
Yeah, so the most of the symptoms are very sort of similar to the normal flu infection, But specifically, if somebody has got sore throat, nasal congestion, cough, those sort of things, they may have, this may be very well due to COVID, but if they have loss of taste sensation or smell sensation, these are the upper respiratory earlier symptoms. And they have this, especially taste and smell sensation, we suspect that it's most likely COVID. Though the flu-like symptoms can well be due to COVID as well.
So following on to that, when should someone test for COVID infection? So they have got flu-like symptoms, as you mentioned, they've got fever, nasal congestion, maybe loss of taste. When should they test for it COVID or contact their doctor?
I think the thing is, it depends on the time, place, person, isn't it? We are going through a huge pandemic at the moment. So anybody actually having these sort of symptoms, they are probably COVID unless proved otherwise. And if they have a family member who is also having a family member or contact, actually relative is suffering from COVID, then obviously they should have the test done. When they are having minimal symptoms, they should have the test done straight away.
So again, I'll ask the same question, maybe to, I think Sumit has joined. Sumit, if I may ask you, someone has got fever. When should they do a COVID test? On day 1, day 2, day 3, or what should be the protocol? Unmute yourself, children.
Hi everyone, sorry for joining late. The highest positivity is day 1 to 3. So I would not delay it, given the fact that now the tests are taking in Calcutta 3 days to come back. By the time you get a test back, if you do it on the 3rd day, you're really into a position where you might be starting to get off. So I would get it the moment. If you have symptoms, day 1 of symptoms, do it. If you don't have symptoms, it's more difficult, but then it depends on the scenario where you're wanting to do the test. It's usually somebody in the family who's got COVID. And then I would say day 8 is a very average place to start off with, or at any symptoms onset. The problem is not after symptoms. The problem is actually before symptoms, as you know, and you may pass on the disease for 48 hours before symptoms. So the testing and then isolation. So you test and you isolate while you're waiting for reports. So if you think about testing, you isolate yourself. That's
okay. Thank you, Sumit. So Jayanti, if I make, Soumitra.
Just a quick recommendation here. I don't know whether it is followed. Let's say the test is done early and the patient has got symptoms, it comes back negative. Here we still recommend to isolate and to repeat the test in 2 or 3 days time. What happening in Kolkata, at least with my relatives, is if it's negative, they're saying, oh, it's negative, and they're going away. So that is what
I think it's a very, very good point. I think for all the juniors, this is something. There will be some tests which will be falsely negative, and it's a very, very good point. Then, Jayanti, if I may come to you, as Chinmay was mentioning, someone is at home. How do they assess mild, moderate disease, or when can they decide that they need to go to the hospital? It will depend on the doctor, obviously, but how can you differentiate between mild and moderate disease at home?
So yes, as Chinmay mentioned, most of these patients will have a flu-like symptom like fever, cough, and some more or less specific COVID symptoms like loss of taste, loss of smell, etc. For me, the key thing is breathlessness. And if you have access to a pulse oximeter, the level of hypoxemia. I'm talking about home management here. If you have a level of oxygen measurement at home, then anything above 94% is regarded as acceptable for home management. And the breathlessness side will probably determine at home whether this disease is mild or moderate in those settings. So if the patient has got no breathlessness or even mild breathlessness, they still can walk about in their house. They're not expected to go out at this stage. They must be self-isolating, and I cannot press how hard it is. If they live in a situation where there are stairs, if they can manage the stairs, then that's mild. If the patient is getting anything more and getting breathless on maybe walking across the hall for a distance, then that would be moderate. And obviously, if they're very, very breathless, even talking and unable to complete sentences, then that would be considered as severe.
Thank you, Jayanti. I think coming to Chinmay once more, Do we do the same thing here in Kolkata? I think the problem is there is a lot of panic at the moment. So a lot of people with mild symptoms are also getting admitted or wanting to get admitted. What
Yes,
would you suggest to
this
the
was
young doctors to advise their patients? When
yeah.
should they contact and try and get admission?
Yeah, no, this was very true in the first sort of wave, but over this last 8 to 10 months or 12 months, actually, most people now actually they know that most of the diseases are not that serious, and most of them want to stay at home. That's the change scenario we are noticing now. But obviously, yes, there is a panic there, and if somebody is having, and most people has got a oximeter at home, and when sometimes the saturation is coming somewhere below 94 or 95, maybe the misplacement of the oximeter, that they panic a lot, and they rush to the hospital. But I think the problem is we are managing too many patients at home at the moment anyway. But the and our life is at a hell, at a sort of hell, obviously. So many phone calls, so many WhatsApps, and these things are going on. But they have to have a contact with someone, a doctor who can advise them time to time that what to do, and how to follow, and when to come to the hospital, that sort of thing. So that part is, I think, lacking everywhere. I think including the developed countries as well.
Okay.
And in India, obviously, this is in a very bad shape at the moment.
Okay. So I think we need to be cautious at home. Make sure that. Sorry, Paula, you were going to say something.
Yeah. Specifically, I think I'll mention, as actually Joyanto mentioned earlier, the patients, those who are at high risk, means not only the viral burden or the symptoms, it's actually the comorbidities as well. Elderly people who has got very poorly controlled diabetes, who has got advanced COPD or chronic kidney disease, or obesity and things like that. This diabetes and obesity, those are the two worst sort of condition actually which affecting badly. So if they have those sort of things, actually they should be hospitalized much earlier than other younger fit patients.
I think Joyanto did mention when we discussed risk factors. Paula, you were saying something?
No, just I wanted to mention that things become much more different and difficult when you are managing kids, small children, where it's
Yes.
very difficult to put the pulse oximeter, where it's difficult to get that. So there you have to look at the respiratory rate, and that becomes
So,
very important.
Paula, that was my next question to you. Special population. I'll cover both children and pregnant women. If you cover both, what should they do at home? Do they need to take any extra precautions? Children and pregnant women.
Yeah, see, children, what happens is you have to look at the respiratory rate, because it's very difficult for you to keep the pulse oximeter in the, like, it's not possible sometimes to keep the pulse oximeter in the finger. So you have to put it in the foot, and they'll move, and it'll get dislodged, and it'll give all sorts of wrong readings, which can cause much more tension and distress to the family. So you have to look at the respiratory rate, age dependent respiratory rate. Say less than 2 months, it will be more than 60. 2 months to 1 year, it will be more than 50. And then 1 year to 5 year, more than 40. Above 5 years, more than 40. So that is the respiratory rate that you see. So 60, 50, 40, 30. That's how you look at the respiratory rate, how it's increasing. If these children are having a high respiratory rate, then you start thinking that they are worsening. So that is very important. And they should be hospitalized at the earliest if they are having these problems.
So the
Majority of
threshold,
the children, yeah,
so the
majority of the
threshold of
children do
admission
very
should
well.
be.
Yeah, majority of the children do very well at home, because most of them, like, less than 5% have emergencies with this COVID. So that is a very good thing, or a fortunate thing with children that we have.
So
And
50. So I'll
pregnant
just
women, if
interrupt.
you say, yeah, pregnant women, if you say that they are at an increased risk, there is a chance of premature labor, there's a chance of abortion, and there's a chance of IUGR in these patients. So particularly if they are affected in the later stages. So now the guidelines have come for vaccination of preterm of pregnant women. So if they are before the third trimester, they can finish the 2 doses. It is advisable to go ahead with
I'll
the
just interrupt
vaccination.
that. There's slight controversy there, Paulo. We'll talk about vaccination. But the reason I brought up pregnant women is now I think this sort of second wave, I think the pregnant women are getting quite affected. So I think we need
Yes,
to be
yes,
very careful. So
yes.
15 seconds to Shoumitro and Shumit. Would you do anything different, anything extra for patients at home to be extra cautious? Any other test you recommend so they know that they need to go to the hospital or contact their GP, apart from the oxygen saturation and respiratory rate? Soumitra, Shumit, anything else?
Only thing rather than just one-off figure, is mainly to look at what's happening to the patient. Let's say the patient respiratory rate is 18, but is going up to a few hours later it's 22 or 24. You do not wait for the patient to go up to 30. You have to be very careful that the patient may deteriorate. Those are warning signs.
With comorbidities especially.
Yeah, obviously with comorbidities.
So
I think there was in this case actually, as we are managing so many patients at home, I think we are also checking the blood test actually for inflammatory markers and things
that's
as well.
the next question. You can answer that, Chinmoy.
Yeah,
What are the laboratory tests we should do at home?
Okay. So laboratory test actually, like any case of fever, we do the complete blood count, infrared marker like CRP. Specifically in case of COVID, we are doing D-dimer, ferritin level, and not all cases, but most cases IL-6 as well, with liver function test and also renal function. Yeah, we are. Yes, we are doing it in so many patients. We are doing it, and when they are terribly high and the patient also symptomatically poor, we are admitting them.
I'll just stop you there. In UK, Soumitra, Jayanto, what would you do this test at home? What would you do at home? Anyone?
I do very little test, to be honest. There is, I was looking at, I see a lot of IL-6 being done for even simpler cases. I don't know about Jayanto, but in our hospital, we hardly do any IL-6 unless it's specifically needed. And there is no relation between even use of tocilizumab and IL-6.
We'll come to that, Soumitra. Shumit, from India at home, what should be?
I do not advise any blood test patients at home unless they have comorbidities. We were doing a lot of rubbish initially, but this ferritin, LDH in hospital, I've stopped them. IL-6, still a few people who, before doing tocilizumab, mostly to console ourselves rather than anything else we are doing, I would absolutely say they are useless in the outpatient.
So
there is no
let me stop all of you there. So for the juniors, I think it's very confusing. Senior doctors giving you different answers. What I will say is things are different in UK and India. However, a lot of doctors will do certain tests at home to be extra safe and maybe decide when they are going to go to the hospital. So people are doing CBC, CRP, but do remember these tests are quite expensive, especially the ferritin IL-6. So I think whatever test you recommend to your patients, you need to be very careful and need to justify why you are doing it. So I will stop it there because I think it will get quite, there will be different opinions there. Now, next question, which I've been asked by the students or the doctor, oxygen at home. So maybe Chinmoy, you can take it again. Who should have oxygen at home? And is it safe to have oxygen at home? And what are the criteria to give oxygen at home?
Oxygen at home, and that also needs regular monitoring actually. So oxygen at home, it will be pretty difficult actually, unless, recently I had to do in a few cases actually where there is patient is not getting any hospital bed or patient does not want to go to bed, go to hospital. So they don't want to get admitted in hospital and the oxygen level is falling persistently below 90%, and they are short of breath progressively. So in those sort of situation, yes, we are using home oxygen in the form of either concentrator or from concentrator or cylinders. And many patients actually improving with that. But in my experience, actually, those who are needing more and more oxygen, most of them need hospitalization or they are actually dying at home.
So, Jayanto, do you use oxygen at home on a regular basis? Did you use it during the pandemic?
So yes, we had some experience with it, and I will explain in what scenario. At the peak of pandemic in UK, which was a few months ago, we were fast running out of beds. So particularly for those patients who were actually weaning off, so we have a level 2 center with high dependency unit. When you can get them off CPAP and reduce their oxygen requirement to 2 liters to maintain their saturation at 94%, we were utilizing that opportunity to send them home. But as Chinmoy says, very important with the regular monitoring. We actually set up a team who were monitoring these patients round the clock, almost for 7 days a week, to be able to pick them up again. And some of them do need readmission if the oxygen level drops. It's not something for the faint-hearted or can be done that easily, but we have done it successfully and created beds for more acutely ill patients.
Those kind of setup is quite difficult here. But Shumit, what's your view on oxygen at home? And a very good question has come in. If someone's oxygen level is below 93 at home, 93 saturation, I mean, will you give steroids at home?
Number one is, I think Joyanto is talking about a different population. This is on discharge from hospital. So there we are pushing people out pretty quickly as well. With if they can arrange oxygen at home, as long as they're stable for 48 hours on that prescribed dose of oxygen. What Chinmoy was talking about is a different kettle of fish. People getting hypoxic on the first appearance at home, and there the answer is they need hospitalization. Okay, but as we know, it's not always available. And then I think we have to give oxygen, but you have to understand that a lot of these patients will die at home unless they get a bed. Some won't, so that's the only hope there is. And certainly below 93, if you do not get a bed, only if you do not get a bed, I'm starting to prescribe steroids at a standard dose because there's no option here. And we know that below 93, there's a
dose of steroids at home.
6 milligram, the recovery trial dose. It's standard 6 milligram dexamethasone. And unless you get dexamethasone tablets, if you don't get them, then of course you can use 32 of methylpred or 40 of prednisolone. But unfortunately, we have started doing that given the situation. But the primary advice is get a bed. We can't get them a bed, then we tell them to keep trying. So you must get into hospital. But for the meantime, you should take steroids.
Shomitra, you were saying something?
Yeah, just a quick point. What Joyanto said, we also did same, but particularly in our hospital, we were so much under pressure with the bed at one stage. A group developed, which is possible in UK, it's difficult in India, is we developed something called COVID at home. So people who were very borderline were being treated by nurse monitoring at home with oxygen and steroid because the bed situation was so dire. And then with the provision that if it drops, then they will be shifted to hospital. So there is some avoidance, hospital avoidance there, but that's quite difficult in Kolkata with because they were intensely monitored.
The next question I'm going to ask all the panelists. I'll start with Paulo. This is a very controversial question again. Someone has COVID at home, mild symptoms. What drugs should they have? Paulo. The reason I'm asking this question, I will tell you, because there has been a question which has come: ivermectin, doxycycline, azithromycin. What should we give?
Other choices I would need, like the Coronil from Ramdev Baba and homeopathic medicines and all those.
Don't go into controversy, Paulo. Very simple question.
Okay, so the question is controversial because basically a mild disease for me in a child, no medicines. If there is fever, paracetamol, plenty of fluids, and just because if they have done a teleconsultation with me and I would like to have them pay my fees, then I would write 2 vitamins for them. Otherwise, they will feel the doctor has not written any medicine. So
well,
that
you have made your point. Shomitra?
Simple paracetamol, that's all.
Chinmoy?
We are still using doxycycline and sometimes ivermectin as well. But the thing is, I think ivermectin, I am not sure, though we are writing quite often. But azithromycin or doxycycline, as you all know, that these are not antiviral. But in our society, in Indian scenario, when the patients are coming, actually the chance of secondary infection is pretty high. So if you give doxycycline for 5 days, suppose somebody is having high fever and sore throat, it will not cause any harm. It might prevent actually the secondary infection. That's the reason. It does not have any antiviral efficacy. So that's true.
I have a problem with that, Chinmoy. The doxycycline was a wonderful drug for the gastroenterologist, and I think it'll become resistant very soon. But
yeah,
do you really think there is an indication to give doxycycline for a fever, proven SARS-CoV infection? Do you think that helps?
No, that's as I said, there is no sort of role in COVID itself.
But we
No
are
role.
prescribing it. That's what I'm asking. Kaushik, what would you do?
As a physician, I prefer to give only paracetamol. I mean, I don't know. I of course do not have a pulmonology background, but looking at the evidences that are there in the literature, I haven't found enough of literature on ivermectin or doxycycline, azithromycin to be
Joanto,
convinced
any
enough to
other
give.
views? Any other views, Joanto?
No, I completely agree. Rehydration, conservative, and paracetamol therapy. It's very unlikely in my experience to get a secondary bacterial infection from COVID. If we are dealing with severe cases, we still probably would use antibiotics, but at home, I will not probably use any other medication. The only exception is, and that I would ask people to watch this space, is a fantastic trial has come out about inhaled steroids.
Yes, I will come to that.
And yeah.
So come to Soumitra, yes?
Quick point about, I don't know what the experience in India is, the lot of use of azithromycin, because a lot of people are on simvastatin nowadays, and there is actually a drug interaction between azithromycin and simvastatin. It can lead to terrible myositis. So that is because in respiratory, we do use azithromycin. I always get them changed to something else. So that's something people have to be careful of.
Sumit, very brief.
Not much available in India, though. Not much in use anyway.
What? Sorry?
The simvastatin we really do not use. In India, it's not very much available.
Okay. And even atorvastatin has got an interaction. Generally, pravastatin and rosuvastatin are probably the ones that better.
Sumit, very briefly, any role of ivermectin?
No. Short, to cut a long story short, the WHO has done a brilliant study of all the randomized controlled trials, and they've showed the only positive ones are the bias studies. So there's a huge amount of emotional baggage with it. It doesn't work. There is no biological plausibility for it to work as well. So I would not use it.
That's okay. That's one. And I will just add to it, ivermectin from a gastroenterologist point of view sometimes causes abnormal liver function test. Yeah. I've actually seen few patients on our ward. They were not given remdesivir because the abdominal liver function was there, and it might have been due to ivermectin.
Can I show you 3 slides?
So
it will take in 1 second on ivermectin. This is just people to be aware of. These are the 3 just people just to be aware of about this ivermectin issue. There's so much ivermectin going on. So this is the first. This is second. And this is third.
Okay. So we have made the point of ivermectin. Coming to now 2 more interesting things, which Joanto briefly mentioned. Inhaled steroids at home. I'm not talking about hospital. Is there any role? And what dose if you're giving it, Joanto?
So yes, this study came because it is felt that people with asthma are doing relatively better than they were expected. So a study has come out from Oxford using a particular type of inhaled steroid, bumetanide, at a dose of 800 micrograms daily, which is quite a high dose. So you have to use 2 puffs twice a day or something like that, or maybe 400 twice a day, something like that. But it is actually showing improvement in terms of the milder ones passing on to severe cases, etc. A longer study is at the moment happening in the UK, but while it is happening, the direction has come from, an interim direction has come from the Chief Executive Officer on the NHS to consider its use. So this is, I just think people should know about it. It's not necessarily that we should start about it. I think the trial is now happening in Calcutta, if I'm right. This is a multi-center trial going on all over the world. It's a relatively cheap medication. I don't see we have much to lose by using it. And this is something worth considering.
Going back to,
hasn't been written yet.
Yeah, so Chinmoy, favipiravir. Is there any role of favipiravir? It was used before. Do you think there is a role?
Honestly, there is a literature says it does not work actually. I have never prescribed favipiravir till now.
That's done. Sumit, something interesting, very small study, role of colchicine. Is there any role of colchicine? Can the juniors give colchicine to the mild disease patients at home?
Yeah, I mean, we are clutching at straws here, but we are clutching at straws actually. So there was one study called the Call Corona study. It was done in a public funded Canadian health system. So there were no sort of big pharma behind it. And the outcomes was less hospitalization. So it's something you can look at the study and decide for yourself. It failed the primary objective, but the secondary objective of hospital admissions was decreased. It's a very innocuous dose, but I would think it is more likely that it's going to work than any of the vitamin C, D, zinc, ivermectin, doxycycline,
vitamins are good in a way because the share market prices are going up. So I think that's good in a way.
Okay, there's very good quality trials in all of those saying that they don't work. So I mean,
so if I just may summarize, I think what the panelists are saying is mainly home treatment is paracetamol, plenty of fluids, maybe a role of inhaled steroids, maybe a role of colchicine. Now, moving on, this is a very interesting, mainly for India. People are at home, I think they're feeling restless. Some people's oxygen are dropping. There are a lot of safe homes now opening across the city and across the state and across India. So which patients should go to the safe home and which patients should be sent to the hospital? The reason I ask this question is because there is complete lack of beds now. There are a lot of patients are being moved to the safe home. Are they really safe for them? Whoever wants to take this, there's this question.
I have been involved in setting up such a, well, let's call it a peripheral satellite center. It is actually one step up from home. There is proper pulse oximetry, which is something most people in India don't have at home. The pulse oximeters they're using are rubbish, and they will show anything from 70 to 100, so you really don't help. Secondly, at least if they merit it, they will get steroids, which is something under supervision can be given. And thirdly, it is useful for, say, a patient who's come for, say, a fracture neck femur and has an incidental COVID positive. Do you want a COVID ward bed to be filled up by this patient? You don't. You just want them to have some blood tests, stay in a place where you can keep an eye on them, and maybe once a day somebody goes and has a look at them and say, what do the orthopods want to do? When do they want to do it? And that sort of. So these three categories are very useful. It's a problem is if some of these patients are going to deteriorate quite rapidly, and then you need to be able to accommodate them somewhere, because otherwise they're just passing the ball up the thing. And for each, I think safe home should be attached to a big hospital, where it will be the responsibility of the hospital to find beds should the patients deteriorate. Otherwise, it's a dead end in itself. There will be some people who will get better just on steroids and a little bit of oxygen at safe homes. So that will take the pressure, some pressure off the hospitals. But then you need an outlet for patients who don't improve.
So you've come to a good point, Sumit, steroids. Now, I think that's a very, very important question because I think the studies have shown that steroid works. So if I may go to Soumitra, which patients would you give steroids? When do you start steroids?
So the steroid, obviously, people know it's a recovery trial that showed the benefit of the steroid. So the patient who were benefited were the ones who were the maximum benefit were the people who were on mechanical ventilator, and then people who were on oxygen. People who were not on oxygen actually did not show any difference compared to the usual care. So people who were not hypoxic did not benefit. And if you actually look at the graph, it's actually they did a bit worse compared to the standard group. So people who are hypoxic, they are the ones who should be given steroids. And as Sumit said, it's dexamethasone 6 milligram, or if dexamethasone is not available, you can use prednisolone 40 milligram.
So Chinmay, in hospital, patient has now got admitted to the hospital, sick patient, low saturations. What doses of steroids are you going to give, and duration, and how do you monitor them?
I think, as mentioned by Sumit or Soumitra, actually standard 6 milligram of dexamethasone once a day, or equivalent dose of methylprednisolone, solumedrol, or similar things we are giving. and the duration actually is somewhere between 3 to 7 days usually. But in severe cases, which the patient was in ventilator or something like that, when we discharge home, we usually have a gradually decreasing dose of steroid for overall 2 weeks or so.
Sumit, I know it's very close to your heart. Misuse of steroids. I think a lot of people are actually getting.
I was actually delayed because I was in a place where I was trying to see the problem. This is a problem of.
We are almost an hour, so please say briefly. So there are still few questions left in brief.
Taking off from where Soumitra left, actually, if you give non-hypoxic patients in the recovery trial steroids, if you give 26 of them steroids, one will die. Number needed to kill is 26. So basically, non-hypoxic patients should not get steroids. You kill them, right? And this is something which needs to be understood. Feeling ill, fever is not an indication for steroids. And there is strong evidence from other databases, and people with rheumatic diseases have been on more than 10 milligrams of steroids. Their mortality has worsened. And people are using CRP to give steroids, and they've shown that less than 100 CRP without hypoxia, there is a twofold increase in mortality. And 100 to 200, it's like equipoise. Above 200 CRP, most of them are hypoxic, will benefit. So the issue is not probably something which UK people will face, but there are powers that be who are trying to push steroids for non-specific indications. And I've tried to, you know what I've done. I've emailed various people.
There's a very nice white paper Sumit has made. I think he probably emailed to you also. Sumit, you were saying something?
Yeah, it's just what Sumit said is a lot of things coming up. People getting like 60 milligrams, 100 milligrams, 160 milligrams of prednisolone. Now, people are quoting this trial called Codex trial that was done in Brazil. Now, if you actually look, the Codex trial was stopped early because of the recovery trial. And as Sumit said, there's a massive harm done to these people. They get secondary infections. It's absolute disaster. So people using steroids, and not only they're using it in sort of various doses, some people getting 3 milligrams, some people getting 15 milligrams, some people getting 20 milligrams. It's quite a random dose all over the place.
So if I may go to Paulo for the children, a pediatric population, what sort of steroids would you give, and do you give it like the adult population with anyone with low saturations?
Yeah, if this child is having low saturations, needed to be hospitalized, then we have only two choices. One is dexamethasone and the other is methylprednisolone. So these are the two drugs that we give, other than the MISC part where you give the higher doses. Otherwise, no.
So now coming to
actually, Devashish, I just have a question to all three pulmonologists, actually, Soumitra, Jayanto, and Sumit. Especially elderly patients, many of them has got underlying COPD, or many patients has got underlying bronchial asthma. So we use in those cases steroid regularly. There is no high incidence of death. So why this so high incidence of death in this case?
Sumit.
And even if your patient, one of your COVID patient has got bronchial asthma or COPD, will you use steroid even they are not hypoxic?
See, the problem is in COPD also increased steroid use increases mortality. Systemic steroids are not to be used in COPD more than 5%.
Exacerbation of COPD.
Yes, even in exacerbation, we don't prefer it. We give inhaled, nebulized, and 5 days of steroids. These people are in a viremic state. So you go by what the outcomes are. If you give these people steroids, you actually worsen the disease early on before hypoxia. You forget that immunity, the inflammation is actually protective. That's how 85% don't require any treatment. Now, if those patients you immune suppress, you make the disease worse. It's only when the inflammation is inappropriate, which by definition is 93%, it could be another definition, that's when steroids work. Timing is crucial. Giving it to people who are not going to get
I think you've made your points. There are a lot of other things to ask also.
On the same point, actually, in recovery trial, the people who had steroids before 7 days did not do so well compared to the people who had steroids after 7 days.
Jayanto, from
Yes.
the UK perspective, a
So,
patient come. No. It's a different question. I want to move on from the controversy of steroids now. So someone comes in with moderate disease, gets admitted in a hospital with COVID. What is the standard line of treatment? So what drugs will you give for those patients?
so this is probably in the UK, patients would be admitted when they are hypoxic. So we are talking about starting them on oxygen, and we would qualify a moderate risk as somebody is on low flow oxygen. So up to say 4 liters of oxygen a minute to maintain a saturation of 94%. The drugs we would use in those cases, apart from the ones that we have already mentioned, are the patients who are on oxygen, as we say, dexamethasone 6 milligrams daily for 10 days. That's our standard dose and standard duration. The other drugs I would consider is remdesivir in those cases. As long as these people are moderate disease, not requiring intubation and mechanical ventilation, I would use remdesivir in addition to the steroid.
So you are talking about moderate disease. Now, going further from that, when do you do a CT scan? Would you do CT scans to all patients? When do you do it?
So personally, I hardly do CT scans. Now, I might be one of these people, because if you have got a patient presenting with a PCR positive classic presentation with a chest X-ray showing pneumonia and the symptoms presenting as pneumonia, I don't think a lot of people would need CT scans.
So you are talking about the admission. If the patient is getting worse, would you do one if it's becoming moderate to severe?
The cases where I would consider a CT specifically is probably when I'm thinking of a complication like pulmonary embolism. We can do a CT pulmonary angiogram to look into that. The second case where I would consider it where the diagnosis is not certain. So I have got a PCR test which sits on the fence, but the patient is behaving as COVID. Sometimes in those cases, a consistent HRCT ground glass changes may push the boundary over to treat it as COVID. But if I have somebody with barn door COVID and I'm treating them as COVID, I do not see how an HRCT will add to its management. Now,
okay. Just hold on there, Janto. Chinmoy, would you agree with that? I think our practice in India is a bit different. Chinmoy first, then Shumit.
Yeah, it's different. Yeah, no, not in mild cases, but moderate to severe cases.
We are talking about moderate cases now.
Yeah, hypoxia. Yeah, those who are having hypoxia or increasing breathlessness, those when they are getting admitted to A&E, most of them are having HRCT, and many of them don't have the COVID report, but they have got a COVID-like symptoms. They or contact many sort of family members are COVID patients or things like that. They are developing hypoxia, progressive shortness of breath, coming through A&E. Whether a COVID positive report is there or not, they are having a HRCT.
Shumit, do you think the HRCT is necessary in all these moderate cases? Because I think we are doing a lot more than the UK doctors.
Three categories. One is diagnostic uncertainty. I don't see patients without RT-PCR reports. I can't tell you, but it is useful. I mean, you got an RT-PCR waiting. Maybe the emergency is backed up. They do an HRCT and say, let's put him on the COVID ward. That's one. Yes, I would do an HRCT. I never asked for an HRCT apart from that. And I don't get involved in the emergency patients, so I really wouldn't know. I only ask for a CTPA. The only indications are worsening, persistent, or unexplained hypoxia. And in that case, it has to come with a caveat that if it's positive, you're going to change some management, in effect, full dose anticoagulation. We do pick up a lot of pneumothoraces and surgical sort of pneumomediastinum, which is not always apparent on the X-ray. So persistent, unexplained, or worsening hypoxia, I always get a CTPA because you don't want to miss the PE. So that's only where I would do it. I never ask for an HRCT. The probable exception is if you have got a renal failure patient, you can't get them die. So maybe an HRCT, I would just want to make sure we're not missing a spontaneous pneumonia. But otherwise, never.
I think for the participants, it's very important what they are saying. However, the RT-PCR tests are taking very long to come at times. So I think there are a lot of centers who are doing screening CT just to look at the lungs. I do understand the points the panelists are making, But do CTs are often getting done because the RT-PCRs are getting dead. Though that's not an excuse, but that's what's happening. Coming to the other treatment, Joyanto, are you using anticoagulants on a regular basis? Moderate patients.
I would answer that, but if I have just 3 seconds to answer one point that Shumit made about HRCT, not CTPA, we must not forget that there is no diagnostic sign on HRCT for COVID. You see bilateral ground glass, and that could be present in other cases as well. I currently have a patient in ITU under my care who had the similar presentation but did not have COVID. That's all I wanted to say. So,
but to be fair now, Joyanto, in this current situation, COVID is your 1, 2, 3 diagnosis. Yes, so I think that you have to give that. So I think I do understand where you're coming from, but for sometimes we have to do HRCT.
As I say,
coming to other treatment modalities. Yeah. So you have we have mentioned about steroids. We have mentioned about anticoagulants.
Yeah.
There are a lot of questions from the participants about plasma therapy. Soumitra, what's your view?
So far as my knowledge goes and the evidence goes, there's not shown any benefit. I think there's a recent study from Birmingham as well, where they haven't shown any benefit on the plasma. I think the first study actually was done in India, I think from ICMR, who did not show any benefit. And there's actually another one that's been done from Birmingham. They've stopped recruiting now.
Chinmoy, would you agree?
Absolutely.
So there is absolutely, so we are all agreeing there's no role of plasma therapy. Coming to the next big one, remdesivir. So maybe start with Shumit. When do you give remdesivir? What is the indication for?
It is NIH and NICE approved, and I would go by the guidelines. And it's consistently, all trials have shown it doesn't improve mortality. So I wouldn't be too fussed about it if I didn't get it. I would not give it in delayed or ventilated patients, as Soumitra was saying, I think. And I wouldn't give it in non-hypoxic patients, except in extreme cases where there's persistent fever, and one would give it, but not in the current situation where we don't have beds. And I would not give it in renal failure patients or patients with transaminitis, or even pregnant ladies. I think there is still no indication for that.
So which patient would you give? What is the criteria?
So it's a hypoxic patient, not on a ventilator, less about 10-day-ish from onset, and not in renal failure, no transaminitis, not pregnant. So that's
Soumitra, would you do the same in UK, or do you?
Absolutely. I'm not a great fan of remdesivir. The only situation where I might use is, let's say a patient is on oxygen, but obviously not on ventilation, just playing oxygen, and the oxygenation is getting worse. And if it's within 10 days, if you have it available, you can give it. But in India, I realize it's very expensive. So you don't want to break your bank. So I'm not a great fan of remdesivir. And as Shumit said, obviously the other contraindication.
Chinmoy, next drug is tocilizumab. Do you use that?
Honestly, I honestly used in 2 of my patients, and in our sort of ICU, they used quite in a few patients actually, but our sort of result is not at all encouraging. Usually, the patient is having, usually on ventilator actually, or they're too much respiratory support, sort of ventilation, and their inflammatory markers are very high, progressive shortness of breath, IL-6, yeah, is very high. And in that sort of situation, we used it, but none of them actually survived. About 8, 9, 10 patients.
Joyanto, your experience on tocilizumab?
So, like Chinmoy, I've used it sparingly, only in patients who are deteriorating and possibly requiring level 2 care or intensive care with a very high CRP. Now, that may be the only indication where you can carry out an IL-6 or even a procalcitonin, but these are very expensive tests.
My question is, how relevant is IL-6 before giving tocilizumab? Shumit, IL-6 and procal. Do you give it at all?
IL-6 has procal we are using a lot because we get lots of bacterial infections, and we try to push it to not use antibiotics. You know, severely ill patients with a high CRP, the knee-jerk reaction is to put them on antibiotics. We use it to militate against antibiotics. So that's procal. IL-6, as Joyanto was saying, none of the trials have used IL-6. So we've gone off the boil. We were using a lot of it initially. So we're not using that much IL-6, but it takes time for bad habits to slowly settle down. It sometimes it's just like a more expensive CRP, which has got a direct relation to the treatment you're giving. And tocilizumab, it's been a sort of a up and down story. We were very initially enthusiastic. Then we said, oh, it doesn't work. And now the couple of huge trials have shown mortality benefit. And in fact, it's as good as steroids in those subgroups. So you have to look very closely in which patients you're going to use it in, because no other treatment has really shown mortality benefit apart from steroids. So we are using it again.
Very briefly, can you mention the subgroup who may benefit from tocilizumab? I think that's a very important point.
Well, tocilizumab is used in patients with a high CRP. The definition is very woolly. The trials have used 75 and above, which is like a lot of patients, but the higher the CRP, the more. It's used within 48 hours of going on to HFNO or non-invasive ventilation, right? So a patient is on oxygen, is deteriorating, and within 24 to 48 hours of requiring sort of BiPAP or NIV, or you give it. There is a contentious indication where people on ordinary oxygen who are progressively deteriorating, 2, 4, 6 liters like that every day, you might give it. One trial has shown benefit, the other has not looked at that. And that is where I think IL-6 might be helpful. And so a very high IL-6 with at that stage might. But the problem is we had lots of we used over 150 patients in the early phases, but now it's not available as much. So it's taking 2-3 days to come, and we're actually missing the window of treatment. The window, the timing is absolutely crucial. If you give it too late, first 48 hours of getting onto NIV or HFNO, and that's it. So that's when you would target it.
Although in the pediatric population, do you use all this? These are all very expensive drugs. Is there any benefit using these in a younger population?
Yes, when these children are deteriorating, number one is IL-6 we rarely do. It's basically a rich man CRP. So there is no big benefit by doing IL-6. We usually monitor these children if they are worsening by doing serial CRPs. And remdesivir, yes, we use if these children, there's no benefit, no studies below 19 years of age that they show that remdesivir can work. But yes, if they are very sick, then there are recommendations of using remdesivir in the dose of 5 milligram per kg on the first day, and thereafter 2.5 mg per kg for 4 days. And tocilizumab, yeah, I have no idea. I've not used tocilizumab in pediatric patients.
Thank you. I think this question is probably anyone you can take. There's a question which has come. How does awake proning work in ventilated patients? Sumit or Soumitra, anyone? Or Janto?
Can I just check? Is it droning or proning? They're asking.
Proning. You're talking about proning. Proning the patient.
P for Papa, P for Peter.
That's right.
Yeah, so the proning is actually quite an effective maneuver in these cases to improve the oxygenation. So when you are ventilating these patients, particularly intubated, ventilated patients.
The question, Jantu, is how does it work?
Yes, so that that's what I'm trying to explain. When these patients are supine, you are losing some of the airways because they are not recruited, because they are gravitationally impaired. So when you are proning, the part of the lungs which were on the bottom, you can almost imagine they're on the top and they would be recruited. So you are recruiting more alveoli. It is similar to how you use PEEP to recruit more airways, recruit more alveoli, sorry, and use oxygenation. So that's how it works. It's an established practice for ARDS, including COVID.
Also,
I think the questioner was asking about awake proning in non-ventilated patients. That is a different thing. Joyanta was explaining proning is very well established in intubated patients and it improves mortality. Awake proning is basically people on oxygen or maybe HFNO or BiPAP, and there is a benefit similar to a ventilated patients, but a mortality benefit is yet to come out, and it works the same way theoretically as John has said. But I think the questioner was asking about those patients, not the ventilated.
No, I think
it has to be done.
Anyway, Shaumitro, I'll just coming to you anyway. There's a question on happy hypoxia. Will you please explain to us happy hypoxia and are the patients at risk of worsening symptoms?
Just a quick point on the awake prone. I don't know what sort of experience. My experience, proning on an awake patient is very difficult because you have to realize these patients are very breathless. So you have to now press their chest against the bed with their face outside the bed for the ventilator, the NIV to go on. It's very difficult for the patients to sustain. Prone ventilation in a mechanically ventilated patient is different because they are anesthetized and you've got a positive pressure. It's very different. So my experience has been the patients don't tolerate it very well, the awake prone ones. I don't know what the others' experience are. And the other
happy hypoxia.
Yeah, happy hypoxia is this thing come up in quite commonly. So basically what happens is that these patients are not very breathless, but they are hypoxic. So that's why they call it like happy hypoxia. I'm not aware what the mechanism is, but the hypoxia is obviously due to the VQ mismatch because of the extensive consolidation. Why it doesn't trigger the breathlessness, I'm not entirely sure the mechanism. But what I certainly would say that these patients be very, very careful, they deteriorate. And some of these patients we have seen deteriorate within an hour to have to be intubated. So that's my advice, that because they're not very breathless, don't take them, sit at home and, oh, they'll get better. No, they're very likely to deteriorate and they can sometimes deteriorate catastrophically quickly.
Okay. Thank you. I'll just ask a few questions which has come up on the chat box. Any role of 2-deoxyglucose? It just come up in the press today. Does anyone want to make any comments? Or we watch the space? Is that the answer?
It'll cure COVID.
I have looked it up yesterday evening because somebody asked me the question. It's been around since 1980, and one of the major trials, the scientific papers, is from the Patanjali Research Institute. Wow. And there is no clinical trial yet being done. I think there's a lot of hype. I'm certain if something comes of it, we'll know in a few months.
So I'll be a bit more diplomatic and I'll say, what's the space? The next question is, both the COVID task force, Government of India and Government of West Bengal endorse use of doxycycline, ivermectin, etc. Who had made those and why? I don't think we're going to answer that. Coming to the next very important topic is, we are also coming to the end of it. I think we have done 1 hour, 20 minutes. So I thought we'd finish in an hour. Recovery and long-term sequelae from COVID. So there's a question which is coming and which is true. People feel quite weak and tired during recovery. Kaushik, anything you suggest? What should they do and what are the options?
Well, I think Jayanto has something more to answer on that particular front.
Okay, Jayanto, if you want to.
So that is a very relevant question that has been asked. And in India, you are going to see it in the next few months. We are seeing a huge pressure on our services, so much so we had to set up a post-COVID, akin to long COVID service. The patient's most common symptoms are fatigue and breathlessness. And they could have other things like cough, joint pains, etc. And they also interestingly describe a symptom called brain fog, confusion, inability to focus. We are not talking about the elderly population here. We're talking about the young people who are actually contributing to the society. These people are unable to do their normal work because of these symptoms. And usually if you follow them, the symptoms are severe when they spent a lot of time in the hospital or had ITU or CPAP or whatever. And so there seems to be a correlation between that. How do we treat it? It is very difficult. It is going to be multidisciplinary. It is not possible for a magic bullet to cure these things. You are going to take, I think the physiotherapists are going to be very important in addressing the breathlessness issue. The other thing, as a respiratory physician or as a physician you might be interested in, is to show whether there is any post-COVID lung fibrosis. That's kind of the only medical issue you can deal with. But fatigue management and maybe support from clinical psychology, we don't have much support here either. But those are the issues that will be coming to your shows soon. That we are.
I'm very surprised, Jayanto, you're not mentioning vitamins, and it would have improved the shares of our companies. Shaumitro, you have seen more than us COVID patients recovered. How much post-COVID lung complications are you seeing?
Right. So there's actually, when the first wave of the COVID hit, we had thought that, particularly, I run an ILD service, so we were thought we would be snowed under with the post-COVID fibrosis. But actually, recently it has been shown, and actually a paper has been, a short paper, it's an observational data from Imperial, saying that about 5 to 6% of the patients are left with post-COVID fibrosis. This is from the first wave. And we are seeing the very similar thing. So what we have noticed is if you do the chest X-ray 6 weeks later, people who had been in ITU or who had quite severe COVID pneumonitis, it's still abnormal. But most of the time, these people, they're recovering at 12 weeks. So delaying any chest X-ray or CT scan till 12 weeks and partly reassure the patient. And actually what we are seeing now from the first COVID wave, the people who are being followed, most of the people, these lung changes improve. And there's very few people who have been left with post-COVID fibrotic disease. So we are hoping, so far, I was on a webinar last week in the National UK webinar, and it's the same experience from most of the centers from Manchester, London, Birmingham, and Papworth, very similar experience. And in our Lancashire, we are seeing a very similar thing that actually very few patients we have seen have got established post-COVID fibrosis. For some reason, this is remodeling. And this is a very similar thing from the first SARS-CoV when they followed up. Very few patients have been left with post-COVID, sort of post-SARS fibrotic disease. So we're just hoping that probably it may not be a major problem, but time will tell.
That's very encouraging to know, Soumitra. Sumit, do we have similar experience here after the first?
I'm following up 12 patients who were intubated and alive. One of them was in May 2020. He's got a normal CT now. I met him on the street the other day. I agree with Soumitra. Just give it time. It all settles down. Of course, there'll be one or two who will be a problem and they'll probably have a secondary thing, but it's just a question of time. And it's probably not post-COVID, it's post-ARDS mostly. Yeah. So, and there are, series of severe ARDS before where the same thing happens. You just give it time, it gets better.
Reassurance is a huge thing. People tend to panic, which is obviously understandable. Young
not only panic, they get put on myriads of rubbish treatment.
Yes,
let's not go there.
There are two interesting questions come up. Is there any justification of giving Eliquis while discharging patients home? Would you give Eliquis on discharge?
You asking me?
Yeah, you can take it.
I just reviewed the literature recently because it was something I was doing, and the answer is no. Short answer is no. Okay. The evidence and the guidelines suggest post-COVID D-dimer stratification and giving anticoagulants is no sort of different from any severe ICU illness. So if you were going to give an ICU patient post-discharge anticoagulation for whatever reason, that's the only time. So for COVID, there is no special thing. The range of DVTs post-COVID in 6 weeks about 3 to 4%, which is like same for other.
So no is the answer. Another question: no. Quarantine period. Should it be 10 days, 14 days, or 17 days? Chinmoy, in India. So Chinmoy, you are mute. Unmute yourself.
I think we are following 17 days guidelines. Yeah.
I think if people are finding it quite difficult to stay for 17 days, but I think that's the thing.
No, I think they've changed it recently. Very recently, they made it 10 days for mild to asymptomatic, 10 days, and 14 days for moderate. Right.
I think the whole guideline is 10 days plus 3 days. 10 days.
Yes, that's 14 days.
3 days for the symptom, no symptoms. So that's very clear.
I think initially they mentioned 17 days here, and I think the center and the state have changed things now. Now, coming to the last topic, vaccination. I think all of us will agree it's probably the most important thing now, and hopefully things will restart again in India. Few questions on vaccination. In Covaxin, what should be the duration between 2 doses? Follow.
Covaxin, the gap between two doses is 28 days. That's it. That is what the studies say. So it's 28
What
days
about
between the two
Covishield, the
doses.
duration between 2 doses?
Covishield, if it is possible, give a gap of 8 weeks. But then in the current scenario, when you have, say it differs. So like where you have a lot of cases going around, again, the pandemic is going up, then you give it a bit early, give a gap of around
Okay.
6 weeks. But when the things were coming down, we were at the end of the slope, then giving a gap of 8 weeks would have been ideal, or even 12 weeks if
So
possible.
another question just come up. Someone has got COVID infection, has recovered. When should he or she have the next dose of vaccine? Chinmay.
I think it should be at least 1 month before giving any vaccine, including COVID vaccine.
Sumit, will you give after 1 month or
Yeah,
give later?
that is the Green Book guidelines from government of UK. The UK has got enough patients to form a database of this, and they've advised 4 weeks from onset of symptoms of COVID. You can take either your first or your second dose, depending on where you got the COVID. So I think that's the only sensible guidelines around at the moment.
Now the next question is again.
One second, Didi. I just wanted to clarify. The government of India has said 14 days, which is actually not correct, because what they have said is 14 days because these patients can go stand in the queue and they can spread the infection, it seems, to the other people. So that is why they should keep a gap of 14 days. I think that is absolutely wrong. We should not. We should be at least a month,
So the
if not
14
3
days
months.
guideline will also come in for blood donation, Paulo. So that is another thing which has come out. It was
Yes.
usually 4
Yes.
weeks. Now they have said 2 weeks. The another question to you, Paulo, vaccination to pregnant and lactating mother. What's the current guideline in India? I'm not talking about abroad, in India.
In India, lactating mothers, it is already allowed. So they say that lactating mothers you can give because the transmission of the virus through the breast milk is very minimal, and even in the vaccine, it does not transmit to the baby. So there is no harm. You can safely give to the lactating mothers. So that is out of question. There is no controversy. Pregnant women, we have to be very cautious. We have to tell them that there are pros and cons. We have to talk to the ladies. They should understand the pros and cons. Actually the cons about the infection per se and the benefits of giving the vaccine. There are no side effects of giving the vaccine at the present moment, and it can be safely given to these mothers, the pregnant women. But then if they are worried about it, then you can delay it. But the harms of having a COVID infection in pregnancy is much more than having the vaccine.
Thank you. I'm going to finish here. But just one more question which has just come up. D-dimer levels. Is there a relevance of D-dimer level to start anticoagulation? Soumitra?
Can I take that? Because
Yes.
again, I've been just reviewing this.
Take it.
Initially, we were risk stratifying in patients according to BTS guidelines and a lot of other guidelines that you get intermediate dose prophylaxis with high D-dimers. That has been debunked. It has been shown in moderately ill patients. There is no correlation between D-dimer levels and outcomes. So right now, the answer is, and this is also agreed by all the guidelines, ACCP guidelines. The BTS still haven't changed their guidelines. I'm sure they will do in a bit. So do not use D-dimers to stratify your patients. It doesn't help. There is a loose correlation between D-dimer level and prognosis, but it doesn't correlate very well with outcomes with anticoagulation.
Now, thank you very much. Thank you to all the panelists. Thank you to all the participants. I think we have done it for 1.5 hours and the time flew. I think thanks to everyone. But I would like to finish with a word of hope. What is the prediction? When is this wave going to finish? Let us try and predict when we are going to see the end of this tremendous difficulties which we are facing now. Who is going to take it first? Chinmay, what do you think?
I think the first thing is nobody knows the answer, but I think we should guess this thing from our experience in Maharashtra. So we are seeing that the Maharashtra state, which is the worst affected one, is going through almost the same level for last 2 to 3 months. If you see that every day, still the number of cases are 50 to 60,000 reported from there.
So Chinmay, give us a prediction for India first and then Kolkata. months, roughly?
I think another 4 to 6 months minimum.
Oh God, Pallab?
It looks like the sea. So we'll get over this second wave. We'll have a third wave and maybe a fourth wave. So the prediction is the third wave is
Kaushik,
going to
are you
come
going
in
to
the
say
end of
anything
this year.
positive, Kaushik?
I think all the predictions have proved themselves to be quite elusive compared to the first. We never had an idea that second wave will hit us so hard. So I'm not very hopeful that this is going to end soon. At least for 6 months, this will continue more or less the same.
Shomitra, from your experience in UK?
Okay, so here, obviously, a much smaller country, a bit more disciplined people probably, I'm not sure, but after the lockdown came in early December, it took us about 3 months before things came down, and vaccination. So you can imagine if in a country like ours, in India, where lockdown like this is very difficult, and with obviously social distancing, what we know, I think this, I had actually told my family that the wave is coming in April, and I think my prediction is the worst wave will be at the end of May and beginning of June. That'll reach the peak. If then the lockdown comes in, that'll go, but at least 3 months minimum, I can say.
Joanto?
Sadly, kind of agree with most of it is said. The only positive thing I could say is that I think with COVID, infection, transmissibility, and fear are inversely proportional. Now you see a lot of fear in the population, and that we had seen in January, February time, and that brought the transmission down because people wear masks. We talked about this masks and distancing. Those two are, I think, going to ultimately help because India would, as we know, struggle to have a full lockdown for a long period.
I'll come to Shumit then. Shumit, there's one question, please answer, because someone is asking about nasal spray. Is there any benefit, do you think, long-term nasal spray use?
No, he wants the NO nasal spray. NO nasal spray.
The NO nasal spray has not reached any clinical trials situation at all. It's a very proof of concept pilot study. I think it's again been media hyped. Watch this space. There may or may not be something in
it. What's your prediction, Shumit?
End of May peak. I don't know when the whether the how long it's going to take for it to come down from the peak. I'm not sure.
I think I'll end in a positive note. I think it'll be probably hopefully a bit earlier than that.
Probably we have reached the peak. It seems to have leveled off. So my guess is that we will be ending by mid-June max.
Good.
So
I think that's but I would just thank everyone again being patient and participating. Wish you all the best. Be strong, and I think for the juniors, all we can do is to try and help as much as we can, and hopefully things will settle down. Please keep reminding people, as everyone said, about wearing masks and keeping distance and washing hands. Be well. Take care, everyone. I think I'll finish my part here. DC, did you want to say something?
All of you stay safe. It's each one of you in India.
And don't attend Kumbh Mela.
DC?
Wonderful session. Thanks to every one of you. And I hope that it will be very encouraging to the young doctors and the others practicing out there in the field. So reassurance to every patient that it's not so bad. We will make it through. Let's hope we get over it. Thank you very much.
Thank you, everyone. Thank you.
Thank you.
Thank you. Thank you. Thank you.